Hi, my name is Lizeth, and this is my Module 5 presentation for Adult Health 1 in Aspen University with Professor Mnvrgdio8. This presentation will be on the eyes and common diseases. Okay, and here is a picture that I drew of the eye. It just shows the different structures of the eye, which I will be going over in a little. The eye is divided into 3 different layers, which will be the external layer, the middle layer, and the outer layer. It also does have an anterior and posterior chamber. The anterior chamber is located between the iris and the posterior surface of the cornea, while the posterior chamber is located between the lens and the posterior surface of the iris. The external ocular structures include the conjunctiva, the sclera, and the cornea. All of these structures, they help protect the eye. The conjunctiva does contain glands that secrete mucus and tears. The sclera is what we know as the white part of the eye. And the cornea kind of controls how much light is allowed into the eye. The curved shape of it will allow light rays to refract, and it helps the retina focus on them. The middle ocular structures include the iris, the pupil, the ciliary body, and the choroid. The iris is what gives the eyes their color, and it contains a small opening in the middle, which is known as the pupil. Now, the pupil is what controls how much light is allowed into the eye. It would either dilate or constrict with the help of the iris through the use of the iris sphincters muscle and the iris dilators muscle. Now the ciliary body, this contains the ciliary muscle. This will help us focus on objects by changing the shape of the lens and refracting light onto the retina. And the ciliary process is what makes the aqueous humor for the anterior and posterior chambers. The choroid is a highly vascular part of the eye, and it is what gives nourishment to the iris, the retina, and the ciliary bodies. The inner ocular structures, these include the lens, the retina, the macula, and the optic nerves. The lens is able to change its shape, and this allows for the focal distance to be altered. This is known as accommodation. The lens also works alongside the cornea to refract light. Now the retina, this is composed mainly of neurons, and it is mainly lines the posterior part of the eye. There are 2 parts that compose the retina. You have the central retina and the peripheral retina. And the central retina is where you could find the macula, and the macula controls the central vision field. In the middle of the macula, you can find the fovea, and this provides the sharpest visual acuity. You can also find cones in the central retina, and these are responsible for central vision and color vision. Rods are going to be found in the peripheral retina, and these can recognize light and dark. Both cones and rods are photoreceptor cells, and they convert light into signals, which are then translated by the nervous system into vision. Then you have optic nerves, or cranial nerve number 2. This conveys visual information to the brain from the retina. The first disease that I chose was age-related macular degeneration. I chose this because this is the most common cause of irreversible central vision loss in the United States. It affects the macula, and there are 2 types. It can be either dry or wet. The dry AMD is the most common type. It is painless, and it is a slow progression of vision loss. Wet AMD is the more severe form, and it is due to abnormal development of blood vessels in or near the macula, and it is responsible for most of the AMD-related blindness. Clinical manifestations of AMD include metamophobia, or vision distortion, scotomas, or blurred and darkened vision. Diagnostic testing includes examining the posterior part of the eye, which is known as ophthalmoscopy, and this is where a healthcare provider can find fatty deposits or fatty proteins known as drusen in the eye. An Amsler grid test can also be used to define the affected area and to further determine the type of AMD. Fundus photography or an IV angiography with fluorescein or indocyanine green dyes can be used. Interprofessional care includes medications that are directly injected into the vitreous fluid, and this helps impede the growth of abnormal blood vessels. These medications include Lucentis and Avastin. Photodynamic therapy, or PDT, is used to destruct abnormal blood vessels in wet AMD. It uses medications such as Visudine, which is an IV, and a cold laser to excite the dye. Verteporfin, or the Visudine, is a photosensitizing drug that becomes active with the low light waves. Because of this reason, the nurse must educate the patient to avoid sunlight and other forms of intense light for at least 5 days after the treatment. The nurse should also encourage the patient to increase consumption of fatty fish, vitamin C, and vitamin E, zinc, and beta-carotene to at least twice per week. The patient should also be warned about smoking, as it is a risk factor, and cessation may help slow down the progression of AMD. Next, we have glaucoma. This is the second leading cause of blindness in the United States, and there are 3 types. You have primary open-angle glaucoma, primary closed-angle glaucoma, and acute closed-angle glaucoma. Glaucoma is caused to an improper balance between the reabsorption and production of the aqueous fluid, where the production or inflow is greater than the reabsorption, the outflow, and this causes increased intraocular pressure. Primary open-angle glaucoma is the most common and causes optical nerve damage. It progresses slowly and is usually noticed when the person has lost peripheral vision. This is known as tunnel vision. In closed-angle glaucoma, the part of the iris where the cornea meets the eye, or where the outflow of the aqueous fluid occurs, is closed, and this is mainly related to the aging process. In acute closed-angle glaucoma, it is due to conditions that cause dilation of the pupil, such as drugs that induce myiasis or dilation. Some clinical manifestations of acute closed-angle glaucoma include severe and sudden pain in or around the eye, colored halos, and ocular redness. Diagnostic testing for glaucoma include measuring the intraocular pressure, lamp microscopy, and measuring the peripheral and central vision losses. Sometimes central vision can remain at 20/20 with severe glaucoma, so a visual field perimetry, or testing the visual field, can help find the subtle changes within the peripheral field during the early stages of glaucoma. Interprofessional care consists of controlling, not curing glaucoma. This is used by therapeutic drugs. However, the nurse should warn the patient about the B-adrenergic blocking glaucoma agents because they are contraindicated against patients who suffer from COPD, heart failure, or have bradycardia. The nurse would need to teach the patient on methods to prevent further visual deterioration and promote adaptation to changes in reduced visual acuity and prevent complications and injury. Lastly, we have retinal detachment, and this disease affects the retina, and it can cause peripheral or central vision loss. Sometimes a small detachment can develop slowly, and it makes the affected individual unaware of the issue. The clinical manifestations can present as photopsia, or flashes of light, floaters, ring or cobweb-like in the field of vision, or a shadow covering part of the vision field. The diagnostics test for retinal detachment include a slit lamp microscopy, or direct ophthalmoscopy, or indirect ophthalmoscopy. Interprofessional care consists of monitoring the retinal break for a detachment, and if there is a detachment, it can be repaired through laser photocoagulation. This creates an inflammatory reaction, or through a cryotherapy, which freezes the retinal break. Scleral buckling can also be used, and this is a method where a band is placed around the globe and it moves the choroid, the sclera, towards the retina. A removal of the vitreous fluid, or a vitrectomy, can also help reduce the pressure from the retina. The nurse should definitely teach the patient about the signs and symptoms of retinal detachment, and they should encourage the patient to wear protective eyewear, such as sunglasses, when they're out in sunny days. I have actually gone through this. I did have a small retinal tear that had to be fixed through surgery. So this is the reason that I decided to choose this as a disease. And it was surprising to learn that there is a 25% chance of the second eye having a retinal detachment. It is a little bit scary for me to think that it could happen to my other eye. So it is definitely good to know the signs and symptoms of when a retinal detachment has happened. And at last, we have the references. Thank you.